Well, good evening, everyone, and welcome. My name is Barbara Slater, and I'm introducing this evening's presentation on behalf of the First Parish in Lincoln's Racial Justice Journey. A special welcome to our speaker, Dr. Thea James, Professor of Emergency Medicine at Boston Medical Center, Boston University School of Medicine, who will be speaking on the topic of race and health equity in Boston. How can we achieve healthy communities for all? And welcome also to Peter Hussey, a member of First Parish in Lincoln, who will be introducing Dr. James and moderating the discussion. Peter is Vice President and Director of RAND Healthcare and a Senior Policy Researcher at the RAND Corporation, which is one of the world's largest health policy research organizations. I'd like also to acknowledge and thank our co-sponsors, the Lincoln Public Library, Lincoln Wide, which stands for Welcome, Inclusion, Diversity, Equity, and the Council on Aging and Human Services. We appreciate the involvement of all these organizations. I'd also like to introduce Sarah Klukowski. I guess it's a second introduction now, Sarah, but we're always glad and relieved to have you managing the Zoom arrangements. And Pam Hurd. I don't know if Pam is on yet, but Pam, if you are, we appreciate the fact that you are going to be helping with the chat this evening. And we ask that you hold your questions until after Dr. James' talk. And then you can put them in the chat, and you can also raise your hand or use your mechanical hand, which will zip you up to the upper left-hand corner of your screen. So let me say just a few words about the racial justice journey and the issues module. The First Parish has embarked on a racial justice journey over this past year. During the summer and fall months, we completed an intensive and informative module examining American history and culture as they've been affected by enslavement and other forms of racism in this country, and particularly in New England. And we're now engaged in our second module, which focuses on contemporary issues of racism and the ways in which racism and racial disparities permeate our lives and are experienced today. So far, we've explored residential patterns shaped by redlining and the intended and unintended consequences of a variety of federal government policies. In our third module, we'll be focusing on actions we can take individually and as a community to reduce the injustices we have observed through the history and the issues modules. So I look forward to the opportunity to hear Dr. James and the opportunity she's providing for us to understand race and health in the greater Boston area through the lens of a physician who has devoted much of her long and distinguished career to exploring and addressing these concerns. So let me welcome Dr. James again, and also welcome Peter, who will introduce Dr. James. And then afterwards, maybe Sarah, I don't know if you have further instructions for us, but you'll let us know. So Peter, for you.
Well, thank you, Barbara. It's such a pleasure to welcome Thea James here to talk about this issue, which is so important. I just have so much respect for the work that she's doing. And I've heard her speak before, and we're in for a real treat. So let me just tell you a little bit about her. So she is the Vice President of Mission and the Associate Chief Medical Officer at Boston Medical Center. And as many of you know, Boston Medical Center is the largest safety net healthcare system in New England, and really at the forefront of addressing health equity in the Boston area. They're building on a rich history in addressing this issue, and recently launched a Health Equity Accelerator, of which Dr. James is the Executive Director. In that role, Dr. James is responsible for coordinating and maximizing BMC's relationships and alliances with a wide range of local partners, state partners, and national partners. including community agencies, housing advocates, and others. And their goal is to foster innovative and effective new models of healthcare to help patients and communities really thrive. And that includes a focus on the intersections of health with wealth, economic mobility, and other upstream drivers of health. Dr. James has also worked to improve health at a global level. She's worked in Haiti and in Africa to implement sustainable healthcare models and ultrasound training, among other things. She has herself trained in emergency medicine, where she got her MD from Georgetown and residency at Boston City Hospital. She served in numerous government advisory roles, including very recently the Mayor's Health Inequities Task Force for the City of Boston, where she provided guidance on addressing inequities associated with the COVID-19 pandemic. And she's a recipient of numerous honors and awards, many to list tonight. So we're very honored to welcome her here tonight to speak with us. So we'll hand it over to her now for make some comments. So please stay on mute through those comments, and then we'll open it up for a question and answer and discussion afterwards. Dr. James, over to you.
Thank you so much, Peter. I really, really appreciate you for the generous introduction. And I also want to thank all of you for inviting me here to be here tonight. I just got off of an hour and a half call, and you know, when I get off of calls like that and then I come to talk about what I'm about to talk about, it just makes me realize, it just makes me turn up the heat, and it just makes me realize just how much work we have to do. And it's, you know, so I just want to read something to you really quick. We've been doing some work with some people for about a month, and somebody wrote something in a piece of document that they sent out. We've been talking about some work we might be able to do together. And they wrote, "Poverty is the main upstream driver of health outcomes and inequities." And I said to the person, I was like, actually, poverty is a downstream consequence of root causes upstream, like structural racism, that create, you know, things that lead to inequities. And it creates inequities that lead to poverty, you know. So that is one of the hardest narratives for people to get. The narrative is so deeply embedded in the fabric of society until I think the only way to disprove it or to show it is to actually do it. And so I'm working on that with great intentionality. And so now I'm going to share my screen. Let's see, I hope this is the right one. Yes. See what's happening here. Can you see my screen?
Yes.
Okay. All right. So without delay, I'll just start. Oh, okay. So as you know, as you just heard, BMC is the largest safety net hospital in New England. 80% of our patients are publicly insured, which means that it's either Medicaid or Medicare, with the majority being Medicaid. 77% of our patients identify as non-white, and 1 in 4 of our patients report housing insecurity. And you know, we have a lot of deep connections, you know, working with the community, because that's where our patients come from. Medicine is an interesting industry. I feel like it was basically built for the healthcare system. I mean, it was built for healthcare systems, healthcare delivery systems. It wasn't really built for people, for patients, and which is why it winds up being, you know, inconvenient for a lot of patients, particularly our patients who really are making tough choices every single day, and they're rational choices. They're very rational choices when they have limited resources and they are choosing to do something like choose to feed their family or pay for rent versus come to an appointment for chemotherapy, because they can't get transportation there without spending that money. They have to decide which way they're going to spend the money. And so rationally, they're choosing survival, and you might say, well, they won't survive without chemo. Well, that's true too. But, it's all about not just them, but their families and everyone. And so, people started talking about social determinants of health some years ago. But way back in, I would say 2017, we started asking ourselves what our role is as a safety net hospital, because our patients are indeed the people I just described who have limited resources and making tough decisions about how to spend those resources every single day. And what we see is the same people who come in with the exact same problems repeatedly. They come into the hospital, the emergency department, we reset them to baseline, we treat them. Like if they come in with diabetes out of control, hypertension out of control, whatever, we reset them to baseline, but then we discharge them back to what's driving it. And so the cycle just continues, it just keeps perpetuating itself. That's not what they teach you in medical school. And so what a lot of times people do is wind up having their own assumptions about why people show up like this. And it's generally something pejorative, about the patient, because people don't engage with patients to find out, what the root causes are. But given that, and given that our patient population, what's happened is, over the years, like I said earlier, we've always been, paying attention to the gaps that our patients have. And so we've created many different things to fill the gaps. Many of these things have been disseminated across the country. Like Children's Health Watch is a big data organization founded at Boston Medical Center. And the Grow Clinic is for kids who are malnourished. They follow these kids for years, maybe 2 years old all the way to 18 years old. The Medical Legal Partnership, which helps with a lot of the policies and things like that, that really can create barriers to people being able to thrive. The Violence Intervention Advocacy Program is one of them that I'm really proud of, because, a lot of kids who come in with gunshot wounds and things like that, people think they are unapproachable and not worth trying to talk to or engage with, because they already have an assumption about who they are, because they are generally people of color, many more males of color than females, and they have a gunshot wound. And so, but what I learned early on about those kids is just paying attention to their tattoos. The tattoos would say things like born to be hated, dying to be loved. Death is nothing, but to live defeated is to die every day. And I realized that those kids were like hopeless. So just to make a long story short, what we did with those kids, we take kids like that, who show up like that, and we transform those kids into kids who become homeowners. They have college degrees, a couple of them MBAs, they become tradespeople, all kinds of things, when you take the opportunity to understand what's happening with them and how that's happened. Street cred is something that was created by 2 residents that do people's taxes, so they can take advantage of earned income tax credit. I think it started in 2016. So far, we've gotten back like $11 million for people. And so there are many things we've done to try to fill the gaps, but not necessarily eliminating the gaps, not necessarily addressing the root causes of how the gaps got created. And so we ask ourselves in 2017, what is the role of a safety net hospital? Is it charity exclusively into perpetuity, or is it in fact equity? And we landed, thankfully, on equity. And some people say, would ask us even then, why do you care? Because there is a direct relationship between the root causes and healthcare outcomes. Because people who have lower income have lower health status, and so do their kids, because they're merely just beneficiaries of their parents' resources. As I was just alluding to and saying, really, people can't prioritize health because they're prioritizing survival. I talked about the vicious cycle of instability. It affects education as well. And the life expectancy between where Boston Medical Center is and right up the street in Back Bay is more than 30 years. And I think you all know, if you ever, I don't know if you saw that series on race in 2017 by the Boston Globe that showed that at that time, Boston was #1 in the country with a median net wealth gap of $247,000 for white people and $8 for Black people. And if you're a Dominican, from the Dominican Republic, it was like 0. And so I'm so inspired by the journey that you all have been on, listening to the agenda that you've been tackling. And I heard redlining mentioned as well. And so I'm preaching to the choir right now on this slide right here, but you'd be surprised how many people are not aware of it. And particularly doctors, when the patients, I'll just frame it this way. You can actually, I don't care what you measure anything. If you measure it by demographics, you already know how it's going to turn out. You already know who's going to do worse. Even if you know nothing about the topic, you already know. And for most people, that's what they expect. It's the status quo, it's the norm. And so even when they see that, it's so much accepted as the norm as they don't see it as an inequity. It's not seen as an inequity because it's an expectation, because that's all you ever see. But I would say that when redlining happened back in the 1930s, I mean, it created at that moment in time by creating barriers to economic inclusion, where people who live behind red lines did not have access to wealth building pathways that President Roosevelt was putting in place, for people to recover from, the Great Depression. Right away, you just create a system of haves and have-nots. Certain people were immediately put on a pathway to building wealth, particularly through home ownership, given the benefits of home equity, and others were not. And there's modern day redlining as well in terms of property value. So that, that kind of thing still goes on. But it's amazing how something like this, when it was established back in the 30s, how it can perpetuate over decades and still you see manifestations of it everywhere. Here's an example. When the first round of the first year in 2020, when the epidemic happened, our hospital became a COVID hospital. I mean, it felt like the building was tilting, that we had so many COVID patients. And on one particular weekend, we actually had to transfer out like 9 people because we just had no more room. We were using every single space as a place to put a bed, as a clinical area. A lot of things turned into clinical spaces that were not intended to be clinical spaces, but just trying to be able to accommodate people. And then, dealing with the ventilators and things like that. And we even had these daily meetings working on crisis standards of care. What would we do if we ran out of ventilators? I mean, it was really, 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 really intense. And it was like a tsunami. I mean, if you look at this slide here, that's the way the numbers just were increasing, like every single day. And most of them came from this map right here, which is the same map, which is the redlining map. The redlining map I showed you is Boston redlining map. And so, again, from the 1930s till now, the pandemic is one way in which this manifested. And now, Boston is not unique because there were cities all over the country with the exact same thing. You could look at the redlining maps for different cities across the country. They look just like these maps and they correlate with COVID. And so we kept these sort of data sheets every week we still do it even now. This one is from the 2020. And, what I would say is that this map is textbook of what I was talking about previously, because the red circles are the neighborhoods people came from. And then when I was talking about education, well, the majority of the patients we had who had COVID had a high school education, as their maximum education. The comorbidities, we had lots of our patients had comorbidities, but these are not people in their 70s and 80s with these comorbidities that like usual. These are people in their 40s with comorbidities, people with hypertension, diabetes, kidney disease, heart disease. I mean, all these things in their 40s. And so, and here's the thing, I was talking about, inequities not being recognizable because they're so accepted as the norm. So everybody knows, we're keeping track of who was doing worse and what neighborhoods they were in. When the vaccines came out, that's not exactly where the sites were deployed. That is, when you think about it, that's public health 101. When there's a problem someplace, you know where to target it. You stop the root right there, or you address the issue right there. But because once again, it's not normal to target these communities, they were, they were left out. And so we decided that at BMC that we had to do something. And so one of the things we did was, but first of all, we recognized we had two problems. We had a problem of hesitancy, and we had a problem of access, because we did some data, and we were surveying people out in the community, looking at what is the likelihood that they would get vaccinated if they had the opportunity to do so. And as you can see what the difference is between patients of different racial groups. But I think at the moment when we saw that, we forgot that our employees actually come from the same neighborhoods, and it was clear to us that something happened here, that the same thing was happening in the hospital. If you look at the colored bar and you look at the top two, the green and the red, the exact same thing was happening in the hospital. So, we knew we had, again, a hesitancy issue and an access issue. So we had to figure out a way to address both. So we had internal things going on which I'll show you in a second, to help our employees, or to target our employees. But we actually went to the community, and we had decided we would not just have these, have a community member, like what organizations usually do, have a community member to sit on a committee to satisfy some governance or something. We decided that we wanted to develop and create and establish an ongoing, robust community relationship where there were many more of them than us. So we hosted several Zooms, and we had two intentions for those Zooms. Number one, we wanted to answer questions about the vaccine from people from the community. And second, we wanted the community to help us to figure out how to address the access problem. And, we engaged with a lot of leaders. We started out with faith-based leaders who actually partnered with our operations teams and our strategy teams, and they would do walkthroughs through various different facilities and buildings, including churches, in the community to figure out where the sites should be, what should they look like, what should they feel like, just creating this together. It was an amazing experience, and we've continued that sort of robust engagement. And what that led to was we were able to establish 6 sites in various different locations in the community as a result of that partnership. We also kept like a 40 some odd page dashboard daily, and we would change operations around and things like that based upon what the data would show from day to day. We would have we would even have hotspots where we knew who, from house to house, who was vaccinated, who wasn't. Someone might show up on your doorstep with someone who's from your community who you trust, and they would also maybe have a nurse with them who was willing to vaccinate anybody, who wanted that. And I just want to just circle back one more moment to where the vaccination sites were deployed when they first came online. One of the things that came up a lot around the pandemic was the community not trusting, the healthcare system, and not trusting the vaccine and the vaccine sites. That's a perfect example of why. Because when you have an opportunity to help people, it didn't happen. And then people wonder why, why there's no trust. So that system that we created, as you can see, it was impactful because this shows the rates that we were able to actually vaccinate various demographic groups with intentionality. And that's the operative word here, I would say. It's all about intentionality. It's just like people who, when you talk about economic mobility in communities, and you talk about wealth building in communities and creating opportunities to close the median net wealth gap. And you have people who just like capitulate to, you can't cure poverty, And if you feel that way, you probably won't, but it's where you set the bar. And it becomes a self-fulfilling prophecy, unfortunately. But thankfully, there are others who, feel different about that. What you can see right here is pictures of, government officials at the different sites. There's Governor Baker at Morningstar, it's Attorney General Maura Healey at the Dorchester site, Russell Auditorium, and then this right here is the Menino YMCA, and that is prior Chief Marty Martinez. He used to be the Chief of Health and Human Services for the city of Boston. So this is some of the internal work we did. We had employees and of all kinds of jobs, doing videos, talking about the vaccine, and I did one myself, and I even talked to myself about not trusting it in the beginning, and how I came to the other side pretty quickly, but I had some reservations in the beginning. And what you see on the right-hand side, also at the bottom, is some of our infectious disease doctors. This woman here is Dr. Sabrina Asumu, and she's all over the news. She still is, quite frankly, because every day we have whatever press is going on and what doctors are attached to it. And she's in there pretty much 3-4 times a week, I would say. See why this thing is doing that. Okay. The other thing we did was to hire a company and to be able to work with various different ethnic groups and in their appropriate languages and culture and things like that. And we sort of dispersed these people out to all the various different communities to do that work. We also had people doing door knocking, as I was saying, doing door hangers, going to bodegas. We had for sorority groups, all kinds of people. We were doing pop-ups all over the place, all kinds of things. And we also work with some young people as well to act as or serve as ambassadors. So I'm going to pivot right here to, what we were doing just when the pandemic happened. When we had asked ourselves that question about what is the role of a safety net hospital, we started to do some things to address that. One of the things we did was join an organization called the Healthcare Anchor Network. It's like a collaboration of 65 healthcare systems, big healthcare systems as well, like Kaiser and people like that around the country. And the goal of that organization is building more inclusive, sustainable local economies through hospitals being intentional about how they make decisions every single day in hiring, investment, and procurement. And I'll give you a couple of examples of what we did in those spaces. So in Massachusetts, when a hospital adds on to its facility, there is you build on to your facility. There is a rule or regulation called determination of need that says that you have to give 5% of the maximum capital cost to the community. And they actually encourage innovative ideas, but nobody really asked permission to do anything innovative. But we asked if we could commit our $6.5 million we had to spend to multiple different housing initiatives. One of them we did was invest in, and believe me, we are, a safety net hospital. So we have super thin margins. We could never like go to our, this would never come off our balance sheet or something. I mean, we couldn't write a check for something like this. But one of the things we did was to invest in a private equity fund. And this particular private equity fund, it aligned with our values because it will only fund housing developers who pass a scoring test. And so whatever they propose has to provide access to employment, green walking space, transit, healthy, affordable food, and affordable housing. And so there was a BIPOC developer for this. Oh, here it is. Here, this particular site. It's called Bartlett Place. 60% of the tradespeople, like the carpenters, electricians, plumbers, all those people, came from the community. So there's an opportunity there to support economic mobility for the population there. It's a 323 unit mixed income unit development. Some of the residences are to rent, but then some are to own. So it provides opportunities for wealth building as well. The people in the building, in the neighborhood, wanted a grocery store on the bottom. And so my colleague and I, Dr. Megan Sandel, we heard of this supermarket. And I can't remember how it got on our radar, but I went to Washington, D.C. and visited the place and stuff. And their values aligned with ours because, they teach people to be entrepreneurs and things like that. And so, but the owners are in Washington, D.C. And then the pandemic happened. And the owner said, well, it's too safe. It's too unsafe to travel. We can't come to Boston. But we'll find you a couple of local operators. And when we met the local operators, they were two men of color who were very well versed in this, the food business. And they've had, properties and stores. One of them has a restaurant. They've been in this business for a while. One of them works with an incubator for Black businesses called Commonwealth Kitchen. The long story short, the pandemic got a lot of people thinking, and we started thinking about this notion of equity. We started to ask ourselves, Megan and I did, why should these guys be operators? Why can't they be owners? Because one of them had an experience where he had a business and he was told in 5 years when the lease was up, he could get another lease. But in 5 years, they priced him out of the lease. And so everything he had put into this business, invested in, he was just lost. And so we were like, yeah, why can't they be the owners? And then we thought, well, why can't they own the bricks and mortar as well? So we had to do a lot. And by the way, we had given these folks, this is another tactic, if you will, or another way of focusing on economic inclusion. We had given them a no interest loan, a no interest loan. And, but now we were thinking about, well, if we want them to be able to own this building, we looked at a pro forma and all this stuff. It's like, why don't we get the other investors to actually change the structure of the loan? Why can't we change some of the debt to like equity and things like that? And so it took us 16 months and we still have, a little bit farther to go to get it all done. I mean, it's all like almost done, to get everybody to change their investment and thing. But I have full confidence that we will pull this over the line, and then that will, these guys will have they'll have wealth, they'll have an opportunity to build wealth. So those are the kinds of things that if people change the way they actually do things, because that's the way the rest of the world does it, it's not clear to me why people choose a different way of engaging with people of color than they would for themselves. I don't, that is something I don't understand, unless you just don't want them to do any better, um, but when you hear people say things like you can't cure poverty, that's one of the reasons why, that they don't try. They don't think that there are other ways to do it. But there's a movement going on right now around economic mobility. The McKinsey Institute has an Institute for Black Economic Mobility. Our new mayor, Mayor Michelle Wu, she hired Shagan Idowu, who actually was the president and CEO of the Black Economic Council of Massachusetts. That's all about, developing businesses and things like that. But they changed the Department of Economic Mobility to Economic Opportunity and Inclusion. So she has an intentionality towards economic inclusion. And so, in the state as well, by the way. So, we are moving in a better direction, to change the way things are. And those things will over time change, change the status of things like the wealth gap. Another thing we did was to invest in innovative stable housing initiative, which really works on policy, and it also works on people, who have emergencies and things like that. That was really great because the two other hospitals invested with us, Children's Hospital and the Brigham. And then we built on top of that by getting other people to join, like Beth Israel joined this year, but we also were able to leverage that to get a JP Morgan Chase Advancing Cities grant, $5 million grant that is focused on not only economic mobility, but also neighborhood revitalization, working with the Land Trust in Dorchester, and working with the Fairmont Corridor, which we're also including. So it's Mattapan, Roxbury, and Dorchester, essentially. We call it place-based because it's those locations, but also we have the hospitals with us again. We also had the city of Boston, engage with us in this deal as well. So it's just like, everybody collaborating together with an intentionality to do something. And so far it has helped us tremendously. And the last thing I want to talk about is the Health Equity Accelerator. So like everyone, over the past 2 years, we have been reflective and thinking about a lot of things. And we decided, we took a year before we did anything, about 11 months before we came out. A lot of people stepped out with their equity banners and things, and we were just trying to figure out, like, how do people all of a sudden understand what equity is? Because they don't understand inequity, because it's more about inequity than equity. So we just really have to think and ponder and do all these things. And, we were looking at these data, these numbers here for Boston. And we were thinking, well, we have to put some intentionality to this. And we also know what some of the roots are. So we want to work on some of the things that are on the right side. But the first thing we did was to say, let's bring 80 some leaders together across the entire enterprise, the entire place. And we took a unique approach. We decided that we would look at the whole enterprise and we would look for inequities. We decided we'd look inside our house and look for inequities. We set up principles because we knew that it would be hard. We knew that we'd find things that would be difficult. And we committed to not blaming and shaming and all that, that we would just support each other through this process. All those areas you see highlighted in dark blue over there, those are all the various different areas we looked, including in HR, looking at jobs throughout the whole organization. And, it's amazing. Some findings surprise some people. I mean, it's really surprised some people. I can tell you as a person of color, you would recognize it in 2 seconds, but some people were really surprised, that they'd never noticed these things before. And again, some of these things are really hard, but I can tell you, we got immediately on that, because what we had decided to do with whatever we find is to, first of all, interrogate it to understand the root, and then do an implementation to course correct, and then set metrics, follow the data out. And so I can give you one example we found was a difference in postpartum hemorrhage in Black and white women. And, postpartum hemorrhage is like women who have bleeding after delivering a baby, after child delivery. And so we started interrogating that. So we said, so what's that associated with? And we saw that it was associated with preeclampsia, another pregnancy condition of like hypertension. And then we backed that up and started to interrogate that to say, okay, so what's the correlation between that and postpartum hemorrhage? So we figured out, well, we knew this, but this is just how we were thinking. I'm giving you examples of how the thinking process happened. The definitive treatment for preeclampsia is delivering the baby. And then we walked backwards some more, and we saw that the correlation between delivering the baby and preeclampsia and postpartum hemorrhage is that the sooner you make the decision to go to C-section to deliver the baby, the less chance of postpartum hemorrhage. And then we noticed that it was taking twice as long to make the decision to take Black women to postpartum hemorrhage. And so the implementation was to remove the subjective decision-making out of the process of when to make the decision. So they standardized the process, and the gap closed right up. It was fascinating to see that. Absolutely fascinating. And that was just an operations thing, but, amazing, just absolutely amazing. So it's that type of approach, our approach to equity. That's what we're trying to do. And it involves all these various different things, including economic justice, because we know that without economic, as long as there's financial insecurity, you can't fix anything. That's the root. People are food insecure because they don't have money, housing insecure because they don't have money, and also because of policies and stuff. But when people don't have stuff, a lot of it's due to, and most often due to money. It's economics, and so we know we have to solve for that first. And I'm willing to take that. I'm ready for that, because I can't take it anymore. I can't take this you can't cure poverty. I just can't hear that anymore. And there are a lot of organizations, again, who are on this path right now. These are the things that the Health Equity Accelerator, is intending to do. It's like a hub and spoke kind of thing. It's kind of like the hub, but it's helping everyone in all the various different, as we call them, verticals. We did the first vertical, and in behavioral health. Oh, by the way, we're also doing a lot of interviews and things like that with the patients and the providers to sort of understand what the decision-making process is about, why there was that difference in the decision-making process. So this thing is going on, and they have other work that they're doing as well in that department. So it's pretty exciting. Again, this is what I was telling you about. We were doing robust community engagement. Well, we have this huge Accelerator Community Advisory Committee. We also have a equity network partnership of people in the community. It's almost like a pie. And each slice of pie is a group of community members working on a different sort of vertical with us. And this is my final slide. This is what our vision is for health equity at BMC, and transforming healthcare to deliver health justice and well-being. So I'm happy to take any questions that people might have.
Well, thank you. That was giving us a lot to think about, and I really appreciate you didn't shy away from the issues, but you also have quite an optimistic view and showed us the path forward. I'm sure there'll be a lot of people with questions, and we will call on people. If you use the raise hand feature, then I will recognize you to come off mute and ask your question. But maybe I could just kick us off with one. There's so much going on here that you've described, and you're partnered with so many organizations. It's really impressive. I was wondering if you had any advice or thoughts about how a community like ours might plug into these efforts. Are there any examples or any guidance you might have for where we might look to help contribute on this?
I would say, number one, reach out to the city of Boston, the city of, the Office of Economic Opportunity and Inclusion. You could also reach out to
I don't know how you do a chat.
The Black Economic Council of Massachusetts. There are others, people like them. And, you could reach out to, I'm thinking about different sorts of like community groups. Most of the people we work with, we are working with them in deals of some sort, like community development, what do you call them? CDFIs, community development,
financial institutions.
Yep. Some housing developers. Mostly things like that. That's generally how we wind up working with people in different things in different areas. King Boston is another thing you could talk to Imari Paris. They are building something in Nubian Square is an organization called Nubian Ascends, ASCENDS. You could Google that and you reach out to them as well, because they're doing a whole development thing. They're about maybe 2 years from breaking ground, but they've got the foundation in there. Listen, I just saw Secretary of Economic Development for the state, Secretary Michael Keneally, give money to them maybe last month, towards that whole Nubian Ascends development. So I said the city because they have their eye on everything. They know everything that's out there. And we actually love working with them, interestingly. It's been good. Yes, it's fascinating. It's fun. It's actually a lot of fun. It really is a lot of fun. But I'm kind of, I really, like I said, I would love to create an ecosystem, an economic mobility, economic inclusion ecosystem, where there's an opportunity to identify a certain geographic area with doing analytics before we identify that before we choose that area, so to make sure where you're able to have impact, and create an ecosystem of not only just like development and business development, but also technical assistance, and creating something that we can actually set metrics for and follow it, and also have a lot of innovative stuff in there. I don't know how much you know about or learned about or read about Tesla, But I have the mindset of Tesla, from the perspective of innovation and not letting, perfect be the enemy of good and all this stuff. I mean, look where it got them, And so just by not taking no for an answer and not following a status quo, just going after it. So.
I had a question.
Thank you. Go ahead, Henry.
Oh,
And
I'm
then
sorry.
Barbara.
Maybe we're not stopping in here. You mentioned a while ago, there's so many initiatives you are working on. It had a prioritized list of some 60 initial initiatives that are embedded across all areas of the system, in which you hope to see progress in the next 12 or 24 hours. How do you prioritize your initiatives? What's the philosophy of the driver?
It's a good question. Yeah, right. So, some of it was the ability to have impact, the ability to actually have a transformative, because we said these are not going to be, we call them initiatives, but this whole movement is not going to be an initiative for us. It's an organizational transformation.
Mhm.
And believe me, they took us through our COO, the second in line to the CEO is he took folks through the ringer. I'm telling you, in terms of choosing initiatives, he's like, because he's a guy who doesn't suffer fools. He doesn't like to just waste time. He's about getting things done and things that have an opportunity to transform things.
Well,
Yeah,
Barbara?
I guess I'm picking up a little bit on Harry's question, but first, thank you so much. There's so many ideas and so much information packed into your talk that for someone who's not in the health field, I'm still absorbing it or trying to absorb it. But one thing that seemed, I'd like a little more clarity on for myself is the administration of it, the management at Boston Medical Center. It seems as the interests and concerns are justifiably diversified into so many different arenas or areas. And how is this managed? What kinds of nodes and networks, et cetera, do you have to accomplish all this?
So when you're talking about the areas I listed for the Health Equity Accelerator,
Mm-hmm.
yeah. So first of all, BMC is a unique organization. We a lot of times, so we have like limited resources and things. Everybody has like 6 jobs, right? And so, but there is a person who's actually the co-executive director with me. Her name is Elena Escobar, Elena Mendez Escobar, and she has a team around her, right? There's a team around her who is responsible for the 6 work groups. And I had a call with them today because, there's a check-in for the work groups next week. And so what they do is they stay after the work groups. It's regular meeting. I think we met like weekly for the first 6 months. And every work group had a couple of people assigned to them who just did lots of due diligence and, just sort of like just made sure that people stayed focused and, whittled down to what they were going to do. So that group was like a bit of a machine, and then not that many of them. There were maybe 5 or 6 of them.
Mm-hmm.
And, they just stay on top of people, and people deliver. And not only that, when we have that group of 80 leaders, nobody wants to be embarrassed. And so, these leaders are like SVPs and VPs and chiefs of departments and things. And they all had to deliver. They all had to report out, on their progress and what they were doing. And everybody had a deck. This group of 6, they would even make your deck for you, make your slides for you and stuff. But It was very, very, very tightly operated and organized.
Yep.
So there was a great deal of accountability involved for people and deliverables.
Thank you. Please join us. Raise your hand if you have a question. I'll go with another one, Dr. James. You know, the COVID vaccination information you showed, I mean, it's kind of stunning. I mean, it's obvious when you look at it. I don't understand how we got to that situation where the vaccination clinics are not in the areas that are served by COVID. I mean, thinking a little bit more broadly, if you walk around Boston, it's hard to throw a stone without hitting a hospital, you know, and sometimes like, you might even hit two hospitals, it'll bounce off one and hit another one.
So
how
true.
are we still, for your patients, how are we, you know, what are you seeing in terms of barriers, access barriers? How is it that people aren't able to access healthcare when we have so much of it in the city?
Well, you know, listen, you know, we were the first first state to do universal, you know, insurance, right? Like everybody, I mean, the uninsured rate, I think, is like 2% or something, you know? But the access issues are, I mean, we serve anybody, right? I mean, we don't turn away anybody. The access issues are, again, money, really. You know, people just can't prioritize it. And so sometimes it's money. Sometimes it's things like people have jobs that they can't take off work, you know, to come for. So one time I had a patient, a resident come to me and say, hey, I have this patient. He's 42 years old. He has hypertension. He comes in like clockwork 4 times a year, gets admitted to the ICU for uncontrolled hypertension. And so I said to the resident, I said, well, what do you think's causing that? And he was like, oh, you know, probably doesn't like take his medication, you know, probably unemployed, you know, and then he goes to his computer and he goes, look at all these no-shows, you know, for his visits, his scheduled primary care visits. So I go in and talk to the guy, and turns out, you know, the man is employed, he has a job, but he can't always afford the prescription, and so he takes the medicine like not like it's prescribed. Like instead of taking it like every day or twice a day, he's taking it every 3 days or whatever, trying to stretch it. He's trying, and then he has a job that doesn't allow him to get to his appointments. 2 problems we can fix. You know, the pharmacy can make an arrangement where we can get the guy the medicine, and all we have to do is make an appointment with the man versus sending him some random appointment in the mail that he can't keep, you know. But what that does is, you know, I mean, hypertension is no joke. You know, you can have stroke, heart attack, kidney disease, all kinds of things from that. And so, you know, it's things like that as well, you know.
With the pandemic, we saw a lot of telemedicine taking off. Does that help for patients like the one you're talking about?
Oh my God, yes. Oh my God. Talk about no-show rates, where particularly in mental health and psychiatry, where we, you know, but in general, where in psychiatry, where we had, I don't know, like a 75% no-show rate, it was the inverse during the pandemic when we got telehealth, you know. I mean, they had a really high show rate, you know, and it says a lot. It says a lot, you know. It was easier for people. Probably people needed it too, but you know, it's just more convenient for people to not have to worry about, you know, trying to get to the hospital and how they're going to do that if they have the resources and all that. But telehealth was incredibly helpful.
Pam.
Yeah. Hi, Dr. James. This is extraordinary. And your story in particular about how the shift, the organizational shift that you've really been propelling. I would love to ask you to talk a little bit more about that. I remember the story of Paul Farmer, and when he said, you know, the WHO asked, so how are you? You know, this is not possible. You're not going to cure TB in, you know, a developing country because they're not going to stay on their meds and they're not going to stay, you know, I've forgotten the term, but they're not going to stay with it. And he said, no, they will, because we're going to have community health workers.
That's
We're going to
right.
have those community health workers. We're going to go down to the community. The community is going to do that. And they're going to be the trusted agents, and they're going to be following up, and they're going to be diligent about it.
Right.
And it reminds, and you know what? WHA said that's not going to happen. And he proved them wrong.
That's right.
This one
sure did.
man proved them
That's right.
wrong. And so I guess my question to you is, I would love for you to share a little bit more. I mean, it's so easy to point out why something can't happen.
Mhm.
And especially when some things are invisible, like structural racism, it's really difficult to put your finger on why it's not going to happen, even though you sort of have this sense. But whether it's affordable housing or access to healthcare, you know, can you talk a little bit about some of the resistance and how you countered that resistance in trying to make this organizational change? Because I see that BMC, in my mind, is no different than, say, a town or a group of people that have a stake in a place. And I'd just love you to just talk a little bit about some of the roadblocks and then how you overcame them.
Well, I mean, the roadblocks are also structural, by the way. I mean, for example, reimbursement rates, for example. If someone has commercial insurance in our hospital, and that commercial insurance also, you know, people in, say, Mass General or somewhere also have the same commercial insurance. And say these two patients are in each hospital, they both have that insurance, and they both get the same treatment. We are reimbursed at a lower rate than the other one, for example. Now, there was an entire expose in the Boston Globe, I don't know, 3-4 years ago about that, but that falls on deaf ears. You know, nothing happens with that, you know. And the other thing, the reason you just keep going is because of what you see every single day. You know, you cannot like turn a blind eye to that. You just cannot do it. I mean, it is the most, you know, you see some of the most unbelievable things, unimaginable things, you know. And, you know, I, for one, have recognized in my whole, I mean, for the entire time I've been a doctor. I mean, because I know better, you know, I know better. I mean, it's like it, I mean, it's just impossible for you not to know, you know, as a person of color. There's no way you can't know it because you see it, you know. And what I most like about my job, in particular, I mean, the clinical part, the administrative part is fun, but it's hard. But the and there's so much accountability attached to that. But in the ER, I love being that person who has the opportunity to face a patient when they come in with all these struggles going on and all these emotions going on. I like being that person who can sit across from that person. And because I sit there and give my undivided attention and just listen, I enjoy watching their demeanor change. And you can see it happen right in front of your eyes. You just watch the whole thing just come down because somebody is actually listening and somebody's actually caring. And I often ask them, as part of my workup, is what would it take for this to not happen again? Which is why I know how it happens. One of the reasons why I ask them, what would it take for this to not happen again? Because until I know that, I can't even begin to know where to start your treatment or your discharge instructions. You know, because medical school teaches you to focus on disease, and that's about it, you know? And so you miss so many chances to alter a person's outcome. I mean, what we're trying to do is alter life course trajectory. You know, not just like drive this vicious cycle, but, you know, like the kids, the violence kids, like changing their entire life. And you have no chance of doing that if you either give up or you have an assumption, some deep narrative going on in your mind, or or you don't listen. I mean,
Thank you. Sounds like we need a site visit.
sure.
Awa, did you have a question? I saw your hand. Yes, there it is.
Thank you very much, Dr. James. My question is, do you have a program where you are mentoring young ones to take in your footsteps after you have moved on? And we hope you stay for very many years, but do you have mentorship program to put together some of this expansive and extensive experiences you've had on the field and how we can take it from there?
I'm sorry. So I'm please forgive me. I was trying to put this together. So you're saying mentorship program for
younger doctors, for members of communities or societies that you are working with? Are there a project or program on a very local level, at a community level, where some of these things are given some energy, some positive energy, so that they can move on? Some of the projects you spoke about.
I see what you're saying. There were pre-COVID. I mean, there were various different things, and generally in the summertime, when they would, have these kind of programs. I'm trying to think of one in particular. Even for people who want to be doctors, younger people who want to be doctors. Bayhek, something like that. But yes, we definitely had that for sure. We had a couple of them, because I know I've talked to these kids and things like that before. Yes, but right now, it's because of the pandemic, it's been difficult. Someone reached out to me last week to ask what they could, somebody from Bain of all places, ask if they could come in and do a volunteer thing for something, but we can't because of the pandemic. I mean, people are taking their masks off, but you won't see that in a hospital, So, so to answer your question, that did exist previously. And I hope I answered
actually.
correctly. Sorry, Peter.
I just was going to follow up with a question that you talked to. I think you said that medical students are not trained to work like this and doing the things that you're doing.
Right.
It's just not part of the model. And have you been able to change that, or do you see that changing? And is there a way that as they're learning how to be doctors, that they're able to be exposed to some of the programs that you're talking about and really work in communities and not just kind of perpetuating the cycle?
They totally can. They absolutely can. I mean, what we do with a lot of groups, particularly residency programs, when they start, they get these tours, into the community of different organizations and things. They also have an advocacy track in some of these residencies. Pediatrics has an advocacy track. In the medical school at BU, they have an advocacy group, and I've talked to them for many times. But what I try to impress upon a lot of these young people, like, they'll come to me with a research project, and you can't tell people what they want to research, but they come to me with a research project, and my question is always like, what do you intend to achieve? What do you tend to change? What is your work going to change? And they generally don't have an answer for that. And it's generally not something that, it's just something, that's generally already out there to begin with. Somebody's, studying some other facet of the same thing. And I'm uninspired by it, to be honest with you, because I want to instill in them early on, like, and they come see me because they like the work, that we do, but I'm trying to get them to realize what they are capable of doing if they want to. They don't have to follow these models. I mean, medical education just needs to be like redone, redone, because there are people in there perpetuating negative stuff even, these kids complain all the time about the racism and stuff they experience in medical school. They complain about it all the time. And so it needs an overhaul for sure. And it causes kids great mental distress. Great mental distress. I remember when I was in med school, I didn't even want them to know I was there. I just wanted to fly so far under the radar. I just didn't want them to know I was there because it just didn't feel safe even, yeah, it just didn't even feel safe. That was the first place and time in my life that I even experienced racism, was in med school. I'll never forget it. It was I forget what genetics professor. And it was very subtle, just a subtle kind of a thing. But even if you never experienced it, as soon as you do, you know what it is. And so, that stuff's not healthy for kids. It's terrible. I mean, people who even aren't minorities go through enough stress in medical school, it's a tough scene. I enjoyed the learning tremendously, but it was a challenge in other ways.
Can I follow up quickly? I'm sorry, Peter. I don't want to talk too much.
Please go ahead. Yes.
So I was in Boston Medical on the 14th of February and on the 27th of February. And I had a long traveled 15 hours, so my left leg was hurting. And that was what took me the first time. And they thought it was a blood clot. And so they did the normal scanning, ultrasound, everything was okay. And then my knee started having a problem. Then I went back there again. And on the 27th, the same side of my body, left leg. And in both occasions, and when I was asking about mentorship, I just want to tie this together. Mm-hmm. I left the hospital feeling I wasn't fully comfortable, which is that way. And I had to call, I come from northern Nigeria, so I have to call Nigerian doctor to ask him, I have been going, I have mass health, I've been getting these bills on the mail, but I am not getting well. And in 2 minutes, he was able to explain to me without me telling him more that the situation I had, and he told me what to do totally differently. He didn't give me medication. He didn't ask me for much information. He knew when I explained to him the pain I was having on my knees. He thought it was the beginning of arthritis. I should stay away from cold. These are like simple things that when you are talking about how you relate to human as human and you can talk to them and follow them up and understand more. I felt part of that, I don't know, that issue of responsibility, or there are certain things doctors cannot do or they have to do. I really felt, a little bit differently, and I don't know how to express it better. And so if you can take what you are doing, what you have said now, and sort of clone it if it is possible. And I don't know whether I'm sure you're doing it, but whether we can have it more expansively. Okay, sorry about it.
Yeah, I try. I do. Believe me, I try. I try in the moment when I'm working. I also, like all of the new doctors, when they first start, they all go through an orientation in this. All of them. It's a hospital-wide orientation. They go through this. I teach the thing. I do the talk. And we also do a hands-on kind of thing as well before COVID. Yeah, we do this every July. And again, when I'm working, I try to do it. Like the example I gave you of the resident who was telling me about this, making these assumptions about this guy with hypertension. I mean, it's another example of where, I try to model that, for them. I totally try for sure, but is again, medicine is steeped in problems, racism being one of them, and not only that, it's steeped in people who they don't. It's like you said, they don't know how to talk to people like human beings. They don't know how to treat people. They just, when you're a medical student, they teach you how. They give you a little booklet and teach you to ask certain questions. You know, um, as if you never met another human being in a social setting or anywhere else. You just start asking questions. There's a lot to be, a lot to be learned in that space. And that you're right, it definitely has to be cultivated. It has to be taught as a part of, the standard education. It has to be, because it's amazing how some of these kids, they don't have any. Actually, even if you had social skills, you could get through it. You could make it work and be impactful. But some of them just, it's just not good. And I'm sorry you had that experience. My spouse has had it too, more times than enough.
Barbara, and then Joan.
It's a question that is a bit broad, perhaps, but it's about trust. And I can see where in your situation you have enormous empathy and direct focus on a patient. So you automatically are able to, or maybe not automatically, but you are readily able to build trust. But we're so lacking in trust across our society now, in sort of every dimension of life. It seems that people are concerned about what's happening, or they feel that they can't be sure that they're being treated fairly or honestly or whatever. And yet the kind of system you're developing, with it's very much community oriented and involving people cooperating together, I'm just wondering how as an institution you're going about trying to transform the communities to be, or the individuals within the communities you're working with, more trustful of one another. Because I think it's got to be such a challenge.
It is, but I feel like, the more they're exposed to positive experiences or respectful experiences, the more likely that is to happen. I mean, we have something called, and this is like unbelievable. We have something called a group called Socially Responsible Surgeons, if you can imagine such a thing. And that is another one of our programs that has been disseminated. I think they have it out at UC Davis now in California. Oh my goodness! I mean, it's like it's incredible. It's incredible, and it was started up by one of the surgical attendings, Dr. Tracy Decker. But so it can happen, it can happen. But again, with intentionality for sure, then, and
maybe that's the key.
yeah, I've actually called out one of my colleagues, one of my attendings once. I came on for a morning shift. He was signing out to me, and he made some off-color comment when they were doing rounds. And after we were done with rounds, I pulled him to the side and I called him on it. I was like, what you just said, what do you think about that? And he's like, yeah, I'm sorry. And I was like, what you do, and as you know, they just soak that right up. And then they model that, And so, I don't know, medicine is the antithesis of what one would hope it would be, given the sensitive nature of the industry and in dealing with people in their most vulnerable moments and things like that. You would hope it would be better.
Joan?
Well, first, I guess I want to say I am so impressed and I feel so grateful for what you're doing. I'm just so moved. I had no idea that people in the hospitals were going out of the hospitals to the community to look at the root problems. I'm just so moved. Thank you.
No, thank you.
And And I wanted to know, do you see any way that the culture in medical school can change? It's
Yes.
just,
It can change. It can change. If they put intention to it, it can absolutely change. There's no question.
how can they get that intention? I mean, what can, you know, I know that there's a lot of pressure on doctors, but I think there's also just a lot of, we've always done it this way. And,
Yeah,
you know,
absolutely. Absolutely. And they're encountering people whose lives they can't imagine in many cases. And they're also making assumptions about people, you know, just based on what they look like and things like that. You know, and they're just perpetuating it. They're making it worse. You know, they're responsible for many of the poor outcomes because a lot of people have a bad encounter and they won't come back. You know, I saw a woman one time who was in her early 40s that had this massive, massive breast lesion. And it was because when she came in to get checked, she didn't have a good experience and she didn't come back, you know, for months. And I've seen the same thing with someone who had fibroids who I thought was actually pregnant. It's a very similar situation. Came in and didn't have a positive experience and didn't come back for months. And so, yeah, it's not good. And I love people. I absolutely love people. I mean, I am energized by patients. I can't wait for them to tell me whatever it is they want to tell me because I just want to I want the opportunity to give them a positive experience. I want to see something change, you know, even if and mainly their perspective, you know, and what's possible.
what I guess partly what I wanted to say is there anything that can motivate a medical school to want to change?
Yeah, like stop funding them. Don't give them any money unless they change, you know, set metrics and things. Seriously,
Mhm.
That
really,
usually works.
Thank you.
that usually
Yeah,
works.
that usually works. I just wanted to cite the question from Roz Delory in the chat, which she asked if Dr. James, you referred to the importance of the support BMC has from the city, and she thinks Roz thinks that the state is also crucial for your work. And how important do you think will the next governor be for your work and for BMC's goals to reach
important.
equity and to be intentional?
Extremely, although I'm just seeing one governor. I'm not even thinking about them all. But I think it'll be extremely important because the state, listen, we are the state's biggest customer, you know, and when it comes to like Medicaid, for example. But here's the thing, and maybe I'll have a better opportunity with the next governor. I mean, when I think about Medicaid and all the subsidies that come out of the state, is I just feel like it's a poor business model. And it's a poor business model for the very reasons we've been talking about, in terms of they just go directly to a charity model. They go straight to subsidies as if that's an end solution to anything. You know, if the money was invested in, for example, you know, we got SNAP and things like that. So SNAP is addressing food insecurity. But imagine if they were thinking of using the money to make it so people never have that problem again. You know, go to the root cause why they have food insecurity. You know, what if that went into, you know, not only like businesses, but, intentional living wage employment and wealth building? What if it went into those kinds of things?
Mm-hmm.
Because we all benefit from economic inclusion because there's more people contributing to the economy, you know? And so, and that would be money going into the economy versus the economy having to take care of these very same people who now have an opportunity to participate in it, you know? And so I just think the business model they just default to that because again, they probably think you can't cure poverty or something like that. So they just throw money away like that.
I'm struck by, and I actually want to ask Peter, if you don't feel put on the spot, Peter, you work so much on policy and focused on health. And I'm wondering what's going through your mind, particularly as somebody who focuses on policy, and what Dr. James is speaking to.
Well, yeah, what I think about is, what are the things that we could do? What are the levers that we could pull from a policy level, at a policy level, to undo some of the structural barriers that she's pointed out? What are the most important? What are the most sensitive touch points that we have there? So, is it Medicaid? Is there something we need to change with Medicaid? How can we get to a delivery system that is actually built around patients and what they need? I mean, what was really striking to me is, it seems, from what her comments are, it's not built for patients at all. What the needs actually are. How did we get there, and what could we do? What does that look like? And then, what are the things that we could do to start to build that? Those are some of the things I'm thinking about, but she's touched on so many important things. I see Mary Gaylord, I think you were trying to ask a question, is that right?
Yes. Oh, whoops. Can you hear me?
I can hear you, yep.
Oh, okay. Thank you, Dr. James. This is it's very inspiring.
Thank you.
I have so many questions, but I'll pick one. The story about addressing the unequal outcomes in maternal care, particularly the treatment of preeclampsia and hypertension and pregnancies, it just hit me between the eyes because my daughter, who is 50 something, and one of my former students, both have lost friends, African-American women, young women who are their contemporaries, to this kind of tragic outcome that you were describing. So I think your solution of removing the subjective element is absolutely brilliant. I can't wait to tell my daughter. I would love to know, have you had luck exporting that concept and also extending it to other kinds of conditions? Because I have also read that infant mortality is badly skewed, and that for whatever reasons, physicians are much less inclined to take measures to save endangered infants of color. What can we do about that? And do you see a path to having this kind of principle work more generally, beyond your own wonderful institution?
No, thank you. Thank you for your kind words. I mean, so that was the first pillar we worked on when we launched the Accelerator, which we just did in like October or something. And that work had been started by the OBGYN department. And, they're still doing a lot of work to figure out root cause and that type thing. They still, they've got, I'm sure will be publishing this and that, and, they haven't done it yet, but they're definitely going to do that. I know that. So we can't move beyond that space just yet.
Mm-hmm.
But they have built a lot of other things around it, like, hiring more people to work on that particular vertical. And so it's going to go places. But that particular model of interrogation, which is our intentionality for the other pillars as well, is to interrogate and not just accept what we see as the norm.
If I may I ask one other question? Your other story, which will stay with me for a long time, about the gentleman who wasn't keeping his appointments and was stretching out his medication. And you said, these are fixable problems. Yes, I love that. When you say you can get him a prescription, for example, I guess the general question would be, are you working within financial constraints that need to be addressed also when you're, having recourse to such measures? He thinks he can't afford his medication. It can be gotten. How does that happen?
BMC magic. No, seriously, BMC magic, as a safety net hospital. I mean, we're not the only ones, but there's a 340B program where, you're able to get medications, at a better cost, a price point, if you will. But the pharmacy can do something for this gentleman,
But where do the funds come from then?
340B is like a government
Okay.
program of some sort,
And this is just something he might not, an individual might not know.
He as an individual can't access that.
Yeah,
like
I
that.
see. I see.
Yeah, that's why I said it's BMC magic.
Yeah.
The hospital has to make that happen.
But more hospitals could make such things happen if they adopted the strategies that you've outlined.
I guess they could, particularly, there's a safety net hospitals fall under a category called America's Essential Hospitals. And they're all, have the same issues,
Mhm.
None of us we all have thin margins. So, and I also feel like in some cases, that's something that gets perpetuated too. Just like poor, people who are from disinvested communities, a lot of times they have a cliff effect. So for example, if you live in public housing, you are limited as to how much money you can earn. And if you earn literally a penny over what the limit is, you will immediately lose the housing. Now, I'm not suggesting that people should be able to live in affordable housing and earn as much as they want, but I think these subsidies should be designed with an intention that people will be able to rise out of it and build it that way. And because otherwise what you do is create a trap, and they will never, be able to get out of it. And so there's something similar about that for safety net hospitals when they receive subsidies as well.
Mhm.
Sometimes, you can be given a target to achieve or a metric to achieve in reducing costs and improving outcomes. And, there can be cases where you make the improvement, you make the case for being able to reduce the cost and improve the outcome. And then you can be told that, oh, we gave you too much money. And, and you have to return whatever, excess or whatever. So, that we also have a poverty trap. I mean, we also have a cliff effect, which is a poverty trap. So that's what I mean about so many of these things are just perpetuated, they just are. And they don't give people a chance to do better or to exit the line of need. Like we have the first food prescription pantry in the country that's also been disseminated around the place. We have a rooftop farm. We have a teaching kitchen. We have all these, various different things, but the way that, and those things, we try to incorporate them, particularly the way we're thinking now, and from an equity perspective, using those things, incorporating those things in the pathways up and out for people, not that we imagine that this is their lot in life, you know, which is, I think, the way society thinks about people. I mean, poverty was created, you know, and you can create ways out of that as well, just by doing things different.
Here, here.
We have a question that came in by private chat, and then I'll go to Jennifer. I think this question was meant for you, Dr. James. So I'll read it. It's a
Okay.
tough one. Part of racism, I believe, is the making of profit by keeping people poor and sick. How and at what levels is this confronted in insurance and medical practice?
It's not. It's not, you know, it's not. It just isn't. You know, most things involving money and, I mean, it is extractive practices, you know, things in which people are exploited in some way, some profit is made or whatever. That's the way, you know, most things operate. You know, there's something right now called the Silver Tsunami. You know, you can relate to that. I see silver line like across my forehead here, and it's where people who are but baby boomers and older, or you know, retiring from their private businesses, and they want to sell them. And usually, you know, there was a different path to that. Private equity people might be interested or whatever, but there's now this opportunity to do ESOPs, and you know, where you have equity shared opportunity plans, where people wind up giving the businesses or selling them to, or transferring them, I meant to say, to their employees. And when employees have equity shares like that, if you compare them to employees in other industries and things, well, like say you have a job at, I don't know where, like, I don't know, anywhere, the city or the post office or anywhere, your actual net wealth goes up like fourfold. Depends upon where you start, but it can go up like fourfold, you know, and that's an interesting way of changing things. So I'm just saying, you were asking me about insurance, but I'm just saying most things are extractive, insurance being one of them. But it doesn't really have to be that way. It just doesn't, you know, people can just perpetuate the same financial models for everything, and they just keep going that way. They're just like extractive and exploitive, and nothing ever changes.
Jennifer Glass.
Jen?
Thank you. I was just wondering, as you've been going through this transformation and doing this work, are you relying on the skill sets of the people already in your organization to try to lead transformational change, or are you working with outside groups to kind of help you look at yourselves from a different angle, or what kind of?
Yeah, we do both, because, for example, the people who are doing the interviews of the patients in the maternal child health piece, they're outside organizations, you know, that we employ oftentimes to do, and sometimes to do, patient interviews, for example. So, I mean, but all the innovative stuff that happens internally. They're just people that just do that stuff. They just do it. They just always are coming up with this or that. And, you know, because we are, you know, a safety net hospital, we have to be innovative. We have to be creative, you know, because, you know, you're making a way out of no way, you know, in many cases. Although we are a $4 billion healthcare system, still, you know, we are able to do things just making a way out of no way. And people reward you for being innovative and creative. You know, it's hard, and nobody's generally going to tell you no. So people are always being creative, always. There's always something going on all the time.
Well, you've been really generous with your time, and you obviously have a lot of other things that you're doing with that time. So thank you so much for being with us.
Thank you.
I just have one last question for you. You showed the picture of when the hospital went on tilt with COVID, and I just was wondering how you are doing and how your colleagues are doing after everything you've been through.
Thank you so much for asking, Peter. It's been a rough couple years. A lot of great resignation stuff and a lot of burnout from people. The hospital has given an incredible amount of support, to people emotionally and that type way. And as you know, like so many people left and then some people went on to be like, there's this like become travel nurses and things like that. And that's mainly about economics, to be really frank. But it's been tough. People are tired, but our rates are way down now. Way down. It's nothing like before. People are actually, somebody approached me about revving up the crisis standards of care conversation again. I'm like, oh my God, that was painful to go through that. But we're doing fine for right now, and a lot of people, put off their whatever illnesses and things they have during the pandemic when it's at its height. They'll stay home and things like that, and then they wind up coming in because, like, I look at the ED census every day, and we're still like some days like pushing 400. All this week it's been between like 330 and like 390 something. So, people are still coming, for sure. It's just that the majority of them right now are not COVID, thankfully.
Peter, are you ready to have me take just a moment to wrap up?
Please do, Barbara. Thank you.
All right, but as Peter did and others, I want to thank you so much for an illuminating and inspiring evening. And I think my takeaway phrase from this is yours. It doesn't have to be this way.
No, it doesn't.
And we could think out of the box, think of new ways and new ideas, and just it's just very, very inspiring, all that you have said. Just in case you have friends who've missed this evening and have been concerned about it, there will be a recording, and so they can hear Dr. James' presentation. And I'd also like to encourage you to come 2 weeks from now, because Dr. James has mentioned several times about wealth creation in Black and Brown communities. And we are going to be having Glenn Lloyd come and speak.
Yes.
Good. Glad
Yes.
you know him.
Fantastic.
Executive Director of the Foundation for Business Equity. And so here is some place where maybe we can take some action or some steps, and we'll begin to link the pieces together and see how they all interact.
He is amazing, by the way.
Good,
Amazing.
Wonderful. All of us should be hearing this. And then one other thing I'd hoped to put in the chat, but somehow I didn't. But there is the first parish in Brookline is having a free screening of a documentary called The Power to Heal. And it's about the historic exclusion of Black Americans from basic healthcare, hospital services, and the training of Black medical professionals. If you will contact me, then I will be, or maybe contact Sarah. Perhaps that's the best way to do it.
I've also put the link in the chat. So if you look in the
thank
chat
you,
right
Sarah.
now,
Good.
scroll up a little bit, you'll see the SurveyMonkey link where you can register.
Excellent. So I intend to watch it, and it's, you can tune into it anytime, Friday, Saturday, or Sunday.
Can I ask you a weird question? Would you be willing to send me the link for Glenn Lloyd's presentation?
We would love to.
Thank you so much. I'd love to hear.
Delighted.
Thank you.
I think I'm just going to jump in here, Dr. James, but I can't help think that you've touched on so many of the points about intersectionality, that economic justice, it's true of the health effects of environment. It is all of these things intersect, and they are, it's never one thing in a silo unto itself. And we've created this.
Yes,
And so we can undo it.
that's for
So
sure.
thank you. Sorry,
Thank
Barbara,
you.
but yes.
Oh,
So yes,
perfect.
we'll send you Glenn Lloyd's thing.
Thank
Yes.
you so much. I appreciate that.
And Barbara, could I just say one
Yes.
thing? And that is that we do have a racial justice newsletter that we send out quite a bit. And I will put in the link when I get it for Dr. James's talk so people can see it, and also the Brookline link. And so I'll try to get it out this week so people will have these links on, before this weekend. But if you're interested in the racial justice news, just go on the church webpage, Sarah. I think it has my email on it, so you can get in touch with me.
And thank you again to our co-sponsors, the Lincoln Library and Lincoln Wide and the COA and the First Parish in Lincoln for hosting this event. And a special thank you to Dr. James and to Peter Hussey for moderating the evening, and to all of you for coming. So we'll
Thank
see you
you.
in 2 weeks, I hope. The
you
24th.
so
for Glenn
much.
Lloyd.
Thank you so much. Appreciate it. Take care.